Well, good morning, everyone. I want to start off by saying thank you so much for inviting me to be here. I was quite excited when Jonathan Jones, via electronic introductions and emails, got in touch with me, like Dana was saying, just to talk a little bit about the collaboration between UCSD and the CHET team and Rady's. And so as the electronic discussions continued, they then transitioned to actual phone conversations, which then I ended up being invited over to look at your 4-bay trauma resuscitation area. And I brought my admin assistant with me, who is a nurse who is looking for a job. And so I try and expose her to as much nursing type things while she is incredibly helpful and useful and my right-hand person in the CHET office. So she came with me. And I have to say, like, the two of us both walked out of there and were like, wow. And it was so cute because we're driving back and she looked at me and she said, with this big wide-eyed grin, and said, do you think I can be one of those trauma nurses one day? I'm like, oh my God, I want to be one too. So I was so impressed and have such respect for what goes on over here. And I really appreciated the opportunity to come over and just get a glimpse into what your world is, and really appreciated your colleagues reaching out to us. So like Dana said, when I had a chance to talk to Juana and meet her as well that same day, and she and I talked a little bit about what kind of objectives you were looking for this particular talk and me being on your agenda. So thank you again for having me on your agenda. It's always a little bit hard to go after Dr. Potenza because I just think he's such an excellent speaker. And so, doggone it, had I known that, I would have asked for a different time slot. So really what this is structured as is really just kind of explaining where CHET came from, where we are, and what kind of resource we can be to you in terms of your pediatric patients, because I do know you see a lot of them over here. And really, a big piece of me being here is for you to put a name with a face. I still do clinical as well, so I still do transport, so chances are we will all still cross paths, which I would love it. But putting a name to a face helps us build those bridges, and I would love for you to contact me with any questions. So I'm not the one who will be handling like pediatric trauma type issues, and honestly, you all do it so excellent and so well. It's easier for me to stand here and tell you about my program. So on here, I don't, for those that, well, I have a feeling, I see actually familiar faces in here. People have been here for a while. I actually have been at Rady's for 16 years. I came as a traveler 16 years ago and then transitioned and just kind of moved through different positions. But just to remind you that in our CHET program, we have the pediatric side, but we also have a neonatal team as well. So what you see in these pictures and what's reflected up here is our neonatal leadership and also our pediatric leadership, and that's where I fall in. So what is CHET? Children's Hospital Emergency Transport. To me, because I live it, it's been my job for the past 10 years, like it seems so easy. But as I have transitioned into this position of being the manager of the team and moved among the community and done a lot of these outreach type of presentations, I realized that, as residents turn over, physicians turn over, staff turn over, people don't know what CHET is. And this was beautifully illustrated to me that even in our own hospital, we do a lot of the IV starts when we're in-house and we're not out transporting. And so my partner and I walked into a room to place an IV in this little boy, and the mom looks up from her book and she says, oh, I thought some dude named Chet was coming to do his IV. And we're like, oh. And it was like this ding, 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 because we're so accustomed to the acronym. So now that we have Rady's in our name, we haven't incorporated the R, so we're still keeping just CHET, Children's Hospital Emergency Transport. So I thought this was interesting in compiling some historical perspective. You look back to 1972 and 1977, where the inception of the neonatal and pediatric programs came from. And it's interesting to see pictures, but also read documentation that, necessity drives us all. And so in the 70s, as San Diego was really starting to embrace its growth process and really starting to boom in terms of the different hospitals and healthcare systems that needed to respond to the community, it became obvious that we as a community needed a means to help our adult facilities move the children to the pediatric specialty. And that's where these teams came from. And so for those of you who've been here for a while and are familiar with Dr. Kaufman and Dr. Peterson, that is the two of them underneath that 1977 picture. And as you can see, we've had some growth over the years. And so Also wanted, like I said, just to reiterate that we are a resource to you and we have a means to help you with some of these things. And as the years have gone on and the program has grown, we now run 4 teams. We have 4 different a fleet of 4 ambulances, 2 fixed wing aircraft, and we're co-branded with Mercy Air. So we have our own dedicated EC-145. We probably won't take a flight over here to you, but we'll happily hop in an ambulance and head over to you. So things, it's interesting for me to see how things have changed over the years. So who is CHET now? Like I was telling you, we have a NICU team and a pediatric team. Both teams have commonalities in their missions, and basically it's to respond to you and to the community and to the needs of the community and provide mobile intensive care units to the community to bring. So what we stress is that it's not so fast or how quick we can get the patient to children's, it's really how quickly we can get to the patient and start that mobile intensive care experience for them. With that being said, there's been great literature and research done too showing that pediatric outcomes and neonate outcomes are much greater if we can get a specialty team to the patient and then escort them back to the pediatric facility. So we have 2 teams here to serve. Just to give you a little bit of background on the NICU team, they do delivery room resuscitation, they do newborn stabilization, they will return convalescing hospitals to their respective hospitals. So if it's a family up in Temecula, like once the baby's getting better, they'll take them back there so that the baby can get better in a facility closer to home. In terms of the PEDS CHET team, we take care of anyone from like 1 day old, and I never anymore put an end age. Because last week I like transported a 42-year-old who had a history of congenital heart defects. I thought, you know what, we're just not going to put end ages on here anymore. So anything from we are prepared to help you out in anywhere from 1 day olds really up until where you need us. We provide immediate response to the community hospitals, to the clinics, to physicians' offices. Both teams are willing and will utilize ground and fixed wing and rotor wing to respond to the needs. Basically, in the end, we'll really go anywhere you need us to. So one of the things that I wanted to let you know, again, as a resource to you, what will help you, regardless of whether you're using the PICU team or the NICU team, we'll speak specifically about the PEDS team. What you get with each call is a mobile intensive care. And with that comes a nurse and a respiratory therapist, both who are intensive care by training and education, but then also they go through a very intensive, rigorous training program that takes about 6 months. So we teach them to intubate, we teach them advanced skills of putting in lines, IOs, thoracentesis, spend time. Actually, we come over here to your sim lab and also to your cadaver lab and utilize some of your teaching opportunities here to teach our team. In addition to, we spend a lot of time in the ORs. Then they transition to an orientation process. And so like I said, this all takes about 6 months to really get a new team member up and moving. All of the team members are expected to be resuscitation code leaders. And what has happened, what has transitioned over the year, and like going back to where necessity like drove all of this, is the physicians who first started these programs would go out on transport, and then there'd be like a second and third call that came in, and there wasn't another physician to go out with the nurse and the respiratory therapist to go pick up these kids. So it started becoming evident that we needed to train and teach our team members how to function without a physician in this transport arena world. So we went from doing about like 20% of our transport without a physician to doing now like 75 to 80% of our transports without a physician. We do have the ability to morph and add a third team member, so we will add a nurse, an ICU nurse practitioner or an ICU fellow if we know like right out of the gate that the kid is super sick and that we really are going to need the extra hands and the extra training. But we do now, like I said, about 80% of our transports are a nurse and a respiratory therapist. But I want you to feel confident and comfortable that you're getting an experienced team who is here to serve and to help. Places we go, like I already mentioned, we pretty much go anywhere you ask us to go. We go off into all over San Diego County, Riverside County. We spend a lot of time out in the desert, out in Imperial County. With Thanksgiving coming up, I don't know if you all have like the same like trepidation that we all have, like, oh my gosh, everyone goes out to the desert and they're out on the ATVs and the motorcycles, right? And like, I mean, we spend so much time Thanksgiving weekend out there in the desert, bringing injured kids back. So we'll go out to Arizona. We often, and like, it's funny, it kind of comes and goes. Like, we'll go to Hawaii, Saipan. It comes in fluctuations, but again, we'll go wherever you need us to. We find our patients pretty much everywhere, in your trauma bays, in the burn unit, in physicians' offices, clinics. If we can get there, we will find a way in the door. These are just some of our transport numbers. I put this in here because it always kind of makes me smile a little bit. You'll see that in the PEDS numbers are the really dark blue ones. And so our numbers were really high at the end of the 1990s. Then we had this huge surge of doing a ton of community outreach, and you'll see that our numbers dropped because we must have done a good job with our community outreach and our teaching, and people start feeling more comfortable about taking care of some of the pediatric patients. So I always tease my team, like, well, teach, but don't teach so well. We need jobs too. So it's always interesting to like track where our teaching occurred and what our numbers are looking like. So as a dedication and a commitment to you, our goal is to be as quickly as responsive, because as you all know, like anytime you pick up the phone, like you want somebody who's going to answer your questions and be out the door. And that's really what we tried to provide. We want to alleviate, stress on different systems. We want to be able to be a part of helping and moving people to the right places where they need to be. When we're coming by ground, we try and be out the door within 10 minutes. If we're coming by helicopter, we try to launch within 15 minutes. Recently, we can't keep our aircraft on our facility because we have so many different patients coming in through other helicopter vendors. So our helicopter it would be constantly like moving in and out to allow the other aircraft to come. So our aircraft is actually now living at Montgomery Field, which is just right up around the road from us. So once we know that we're activated by ground, it's to us in like 3 minutes, and we're usually launched like within 5. So this 15-minute, we've been able to actually improve this 15-minute launch time. And if we're going by airplane, we're wheels up within 30 minutes of being activated. To help give you a little bit more feeling and confidence of the resources that we can help be to you when we're not out in the community transporting, when we're in-house, all of our CHET personnel go to the code blues. We're now the code gray responders, and we've had a lot of really, I'm preaching to the choir. We've had a lot of really like irate family and parents and some volatile situations that now we have a code gray response to. And so our transport team members go to that as well. They do rapid response. All of our transport personnel are trauma team members. The nurses are expected to be TNTLs. And actually the last time I was in this room was last January of 2012. I did ATC and ATLS here. It was awesome. It was such a great class. I so appreciated being here. As well as our respiratory therapists are expected to be trauma leads and trauma teachers in our trauma resource base. We do, like I was telling you, we do IV starts within the hospital, and we're all expected to be critical crew members on the air ambulances. Do that. We're very fortunate because of how this program has grown that we get to be involved with a lot of public relations opportunities. All of our team members are pretty outgoing, like fun, friendly people, and love to do outreach. So if you even have more classes coming up where you would like specific topics, pediatric topics taught, please be in touch with me, because we will happily orchestrate and arrange to have people come over and participate in any more of your upcoming learning days. So here are our CHET team phone numbers. The NICU team has a different number than we do. Our PICU CHET team member, and you don't need to memorize this because I brought Halloween goodies with me that contain all of our transport numbers on here for you. So the PICU CHET number, that 3404 number, that top number, that is the one that directly calls right into our dispatch, and I would say don't hesitate to use it. If you know that if you have a pediatric patient that comes in and you're not sure whether the child needs to be transported or not, call anyway, because the sooner that phone call enters the system, the faster we can start mobilizing our teams, get the physicians connected, and really be out the door. Sometimes even your physicians just need some advice, or they want to like bounce an idea off of someone. Have them use that number. That's a perfect way. It's a good entry into the system, and then we can connect the dots as we need to as the conversation evolves. If you just wanted to talk to the team on shift, you had a question or you're just wondering what was going on, that's that second number. I will say that number doesn't always get answered, because if the team is out or they're in the middle of a trauma, or they're out doing something else, that phone won't get answered, whereas the 3404 number is the emergent line, and that one always gets answered 100% of the time. And if it doesn't, please tell me. So when I talked to Jonathan, he was asking, like, well, what are some of the things that we can do to help transfers between UCSD and CHET actually go a little bit smoother? And I kind of smiled and said, like, nothing. You guys are excellent. This is one of my favorite places to come. I love coming over here to pick up patients, but also it's always enjoyable to me to interact with the staff. And I say that sincerely. I learn something every time I come over here. So just a couple little tidbits, and these are all things that you all do very well and you do anyway. I would like to say again, call the CHET line as soon as possible. Like, if a kid rolls in and you just think that maybe you're going to need some help, or maybe he or she's going to go out, call it and we'll get things moving for you. The other piece of that too is that we can help facilitate the trauma surgeon to trauma, especially since we're speaking specifically of traumas, we can help facilitate that contact, because I've heard we have a little bit of smoothing out to do on our end, and I think sometimes what happens is that your trauma surgeons will call over to the hospital and they end up going through the operator, who then has to page our on-call trauma surgeon, and like each step of that process delays it by like a minute, 2 minutes. You all are busy, it's hard to stand by a phone waiting for that phone call to come back. If you use the CHET line, especially if you know that you need to be speaking to a trauma surgeon, we can help facilitate that process. So again, that's another number for you to use and to advise, that is a resource to you to help smooth this out a little bit and make your lives a little bit easier. And I think you're all very accustomed to the physician. If I was to run in and grab a patient and walk out and say, like, these are the things that I absolutely want before I walk out and everything else can fall into place, the physician transfer summary stating that the child needs the pediatric specialty is, we would like to have that. The CD, if any films or images are done, so we would like to take the CD or the film, and it is necessary to take with us. And this is universal in terms of radiology liability and how some of these regulations are driven, that the preliminary read needs to come with us. Sometimes those things get separated, and it's one of the things I always try and make sure that if I'm packing a child up or a patient up for someone else to pick up, to make sure that those two things are living together, the read and the images. The notations on the labs that were done, and I know, especially in a trauma resuscitation situation, that your labs come back quickly, but if for some reason you didn't have them, just a number that we could call, or that our physicians could call, to get the rest of that information. Another piece that seems to pop up a lot is that if the C-spine is cleared, which it probably most likely is here in your institution, just a notation of who the trauma surgeon was that did it, so that we can pass it on to our staff, because our protocol and the way that our surgeons prefer that we operate is that if we don't know who cleared the C-spine, or if it really truly was cleared, we have to put them back in C-spine. And it always causes this like awkward feeling for all of us, like for you, for us, because you like wrestle this 4-year-old like back into C-spine, and it just feels awkward on all levels. So if it does get cleared, just help us identify who the trauma surgeon was that did it, and then we can all be at peace with the situation. And then your typical transfer paperwork, like I said, you all do it so well. I feel like the flow is pretty seamless. And another piece that's always helpful is just a phone number of contact that we can pass on to who we drop the patient off with, like, hey, if you have any questions, give a call into this unit and this person can probably help you, direct you. That's always helpful to pass off a contact phone number. One of the benefits of CHET coming to get a patient is that you don't have to give report again. You give report to all of us, we gather all the information, and then you're done. When we walk out of there, you're signed off on that patient, so you don't have to call the referring facility, try and track down the nurse or the physician, or talk to the emergency room and figure out where the kid's going. We'll take care of all of that for you. So it helps make things a little bit easier for you in the midst of your busy days. The one big benefit of using CHET as it pertains to trauma, especially if we're moving trauma kids from your facility to us, is that we can direct admit, especially because you've done all the resus. You've done the assessment, you've done the evaluation. Instead of us taking that trauma patient back through our emergency room, having the trauma team activated and all redone, we can take everything that you've done, your images, your assessments, your notes, the labs, the reports from your physicians, from your staff, and direct admit, especially if, like, we often will get, kids with bleeds that they're completely awake, alert, oriented, but we need to watch them overnight or whatnot. You know, their GCS is 15, but they need to be admitted to the intensive care unit for overnight observation. This is one of the big benefits, is we can move them from your facility right into their bed space versus having to go through the trauma room again and have them completely reevaluated. When that happens, when we move them to the trauma space, the trauma team comes to the ICU and does an evaluation there. And actually, this benefit of using CHET applies to all patients. If you are moving someone from emergency room or from wherever, we can direct admit them. And again, it makes your life a little bit easier, because once you pack everything up and the two of us sign and we walk out the door, your responsibility with that patient is done. You don't need to make any more phone calls trying to track down nurses or receiving staff. We'll take care of all of that for you. So our motto is caring for the future, and this picture was taken completely randomly, like walking out of work one day. The ambulance had just pulled in just as the helicopter was landing, and I used like this little like dinky point and shoot camera to take it, and it ended up turning out very well. Does anyone have any questions?